I'm Ashma Baruwal, and joining us today is Dr. Kim Parker-Guerrero, an expert in trauma-informed care for adults and kids with pelvic disorders. She's also the owner of Renew Physical Therapy in Roswell, New Mexico, where she specializes in pelvic health for men, women, children, and gender-affirming care. Dr. Kim Parker-Guerrero is also the president of the Academy of Pelvic Health Physical Therapy and a delegate to the APTA House of Delegates. A strong advocate and leader, she is quite literally helping shape the future of this field at the highest level. Welcome to Myths to Medicine, Dr. Kim. Thank you so much for being here.
Thank you so much. I'm excited to talk to you.
So let's begin by what drew you to pelvic health physical therapy.
Yes. So I've been a physical therapist for many years and in multiple settings. And one thing I noticed, my physical therapist would come to me when they were seeing what we call regular physical therapy patients, low back pain, SI joint pain. And they would come to me and say they're complaining of urinary incontinence or fecal incontinence or pain with sex. I don't know what to do with them. And so it started out, that kind of piqued my interest right about the time that pelvic health physical therapy was being actually developed and promoted in our Academy of Physical Therapy Association in the US. So
Mhm.
I started taking courses and I started out with just female urinary incontinence. Seeing those patients, they would then tell me about their husbands. So I started treating their husbands. Or they
Oh.
tell me about their daughter or granddaughter who was having
Mhm.
problems after pregnancy or before pregnancy. So it really encompasses so many different things, and it's a quality of life issue. And it's so fulfilling to help these people get back their quality of life and understand that they just don't have to live with this.
Mm. That's true. Pelvic health touches almost everybody across all aspects, all across all spectrum, yet
Right.
so few of us know it as a specialty.
Right.
And I'm glad
Right.
we're having this conversation today, which also leads me to ask, since you treat men, women, children,
Mhm.
what is the common thread you see in all pelvic health patients, regardless of age and identity?
It's really poor bowel and bladder habits.
Oh.
Especially a good example are my teachers and nurses.
Mhm.
They've trained their bladder to, they don't drink enough fluids and then they hold their urine all day long. And then at night, or then afterwards, they overload with fluids because they're thirsty. And then they're
Mhm.
up all night. And it's the same thing with kiddos. A lot of times it's even for little ones. I've seen little ones who've had problems with constipation because they're afraid of having a bowel movement. So we work with toys and different things to teach them how to have like a fun and safe toileting experience.
Fine.
But it's the same with adults. They strain when they try to have a bowel movement or they eat the wrong foods and they're constipated. So it's really some of the same principles across the age spectrum.
Mhm. So that's interesting how it carries on from childhood to adulthood. Pretty much, it could be the same thing, and they might not even realize that it's a pelvic health disorder.
Right, right. And I have some of my women who will say, I was a bedwetter. And, then I grew out of that, but now I'm older and I'm wetting the bed. So, does this mean something's wrong with me? And that's what
Right.
I try to really instill in my patients. You're not broken. There's nothing wrong with you. I help teach them the anatomy and how their body works because,
Mhm.
especially, my female patients, we talk about nobody really talks to us about our anatomy, right?
Mhm.
Nobody
Right.
really, you may get a little information when you're getting ready to start your period, but
Uh-huh.
otherwise, it's just you're on your own unless you have problems, pain with sex, or pregnancy related problems. You really don't have any information. And then you
Right.
get to perimenopause and menopause,
Mhm.
and you don't understand the hormonal changes. And then you're like, my
Right.
gosh, I'm broken. And or you think, this is just normal. My mom or my grandma and my aunt always wet themselves. So I guess this is me. I'm just getting old. And it's
Yeah.
like, no, you're not. So
Mhm.
it's just, there's a lot of education um, that goes with this.
Exactly. And which leads me to my next question, because there are so many symptoms that we have sort of normalized over the years. We do not think of it as a symptom or not knowing it. We do not even know that there's help available, especially with
Right.
women. What are the most common symptoms that people have normalized for years that they could be related to pelvic health?
So like with sexual intercourse, so some people, some of my women will say that it's just normal for sex to be painful. Some of that may be from their background on how they've looked at intercourse, but some of it is because they carry that into their body. It's they have muscle tension down there and they have pain, but they just think that's part of sex. And so until you start working with them and tell them it didn't have to be like this, and
Mhm.
let's look at these muscles, they're shocked that they don't have to live like that for the rest of their life. Same thing with women who start having leakage. One of the first thing I'll ask is, when was your last bowel movement? Because studies have shown with kids too, if you have constipation, that's
Uh-huh.
gonna put pressure on your bladder. You're gonna be more likely to have accidents. So I always ask about, bowel issues, even if I'm talking about urinary incontinence, because
Mhm.
they're together, because of how our anatomy is.
Uh,
And then it kinda keeps going because if you're constipated, men, women, or whatever, and we tend to hold our breath and strain, then for women, that can lead to prolapse.
mm.
Because you're straining all the time.
Oh,
So
that's
it's
awesome.
one of those things you're trying to be preventive. And I've had women that have come in that have had urinary incontinence forever. But they say, I don't want an internal exam. I don't want a pelvic exam. I don't want anything like that. And so I just put them on a bowel and bladder program. And a lot of them get better just like that.
Oh, wow.
They have no complaints of leakage.
Which also was my next question when you mentioned urinary incontinence. What are the biggest myths about it, and what most people do not know about, like what they do not know about the treatment options?
One of the myths is that because you are getting older, that it's gonna be normal to leak urine. That's not the case. There's different reasons that you can have stress incontinence or urge incontinence, but we can work with those. It's not something that is going to just be a part of your life as you get older. And the sooner you start, the better, so that you get better bowel and bladder habits and those
Hmm.
kind of things. Also, with sexual intercourse, there's some myths that sex is always going to be painful. I have patients who they just accepted that pain goes along with intercourse. And some of that has to do with maybe what they believe is right or wrong with intercourse, but also it could be with their muscles, their pelvic floor muscles, and we can fix that. But a lot of it too is, I think we just don't understand our bodies. We don't know our bodies. And so a lot of what I do is educating them on the anatomy, whether it's male, female, or a child, doing it child appropriate communication. But it's educating and knowing what your body can do, but also knowing how our nervous system affects our muscles and our pelvic floor. Those are muscles. So we tell people, I try to explain a lot of that is that you think you're broken, but you're not broken.
That is, I think that's a very helpful and motivating to patients also, because when it comes to women's health, I think that's how it's been inbuilt for us, or normalized that it's
Yeah.
how my body is.
Right.
This is how
Right.
it's going to work.
Right.
But you putting it out there that we're not broken, and then this is something that we can work together and fix it. It is very helpful.
And it's
Hmm.
all about communication too, because for a lot of people, this is very embarrassing to talk about, whether it's, urinary incontinence or pelvic pain, because you feel like a lot of patients feel like they're the only ones that this has happened to, or they've done something wrong, or their body's wrong, or whatever. And so it's just trying to normalize those things and help them be in control of their body. Like I joke with my patients, and making sure that they're in control of their bladder and their bladder's not in control of them. So,
That's a
right,
good way, your own
right. Yeah, your own advocate. That's right. That's right.
yeah. Say.
So,
So, as a patient, how do I know, or even if I'm not a patient, if I am to check it at home, how do I know my pelvic floor is weak? Is there any way of knowing it?
yeah, I mean, so your pelvic floor is part of your core. It works with your abs, your transverse abdominals, and then your multifidi, your low back muscles. And so a lot of times you may have, especially for women, you may have some back pain. You may notice that you feel pressure or heaviness down in your pelvis. And especially at the end of the day, because gravity works on our muscles. right? So toward the end of the day, you'll feel that. One of the things that a lot of people see on the internet, they'll say, train your pelvic floor muscles by stopping urine and do that,
Mhm.
so many times on the toilet. That's the worst thing you can do. But I tell patients, you can do it one time to see if you can stop the urine flow, but don't do that as an exercise because then you're retaining urine. And so that's one of the things. But the other thing I was going to say, a common myth is that Kegels are for everybody. And
Right.
if you go on the internet, it's like you can see all these different ways and different programs on doing a gazillion Kegels a day. And not everybody needs to do Kegels. If you come to me with pelvic pain, that's usually because you have overactive pelvic floor muscles. And I'm going to tell you, do not do Kegels. For my men who have prostatitis, and I tell them do not do Kegels, or if they have rectal anal spasms, I tell them don't do. It's not about training the muscles to up, to contract up. It's about down training them. So I have to teach them the opposite thing with breathing and with how to use their muscles to drop their pelvic floor muscles. So to down train them. So that's why Kegels, that's the other big myth is that Kegels are for everybody. They're not.
Exactly. I mean, that was my next question because whenever we talk about pelvic health, Kegels is something that's mentioned almost parallelly.
Right.
I was about to ask, is that accurate? And as you just mentioned it, I probably was doing it wrong, or I might not have needed it, but I was doing it nevertheless.
Right. And so what we want to do is work with our breathing because your diaphragm and then your pelvic diaphragm, your pelvic floor, it acts as a piston. So you want to contract your pelvic floor, but also exhale. So we breathe in and we relax our pelvic floor muscles. And then when we blow out, we contract our pelvic floor muscles. So it's like a contraction, but it's with breathing. So I could have somebody on the bed if they're just doing Kegels and they're not breathing, because I have some people, they hold their breath and they're doing their Kegels, and I'm doing a pelvic exam. I'm like, nothing is happening down here, but your butt muscles are going. And so it's helping them isolate their pelvic floor muscles. So if you tell me I'm doing a Kegel, I'm going to check and make sure that you're actually contracting those pelvic floor muscles and not holding your breath or contracting your glutes, your butt muscles. Um, and so, yeah, so it's all about the breathing and the Kegels. But my other thing that I do in my clinic is once I teach you how to do a Kegel properly, I'm not going to keep you on the bed and having you doing a bunch of Kegels. What I'm going to do is teach you how to use those Kegels and your ab muscles. So, what we call a pelvic brace. And I get you up and we practice lifting the baby, reaching overhead, all those things that we need our pelvic floor to stabilize. We practice that in the clinic. So I can see how they're doing the breathing and that they're doing their pelvic floor contraction right.
I think that's very helpful. I'm pretty sure I can speak at least for my friends and my relatives all around. We were pretty much doing it wrong if I
Yeah,
am to
yeah.
listen to
Most
you
people, no,
correctly.
most, and that's true because, and so that's my frustration when some patients are sent home by their doctors or their providers, and they say, "Just do 1,000 Kegels or 100 Kegels a day," or whatever. But the patient doesn't, they come in and they're like, "I'm doing Kegels and I'm still leaking," or, "I still feel pressure down there." And then I'll say, "Well, show me." And what they're doing is they're holding their breath and they think they're Kegeling, but they're actually doing a Valsalva.
That's incredible information, and I'm sure a lot of our viewers will really learn something new today when it comes to Kegels exercises.
Yeah, yeah. So, and that's the thing, one program doesn't fit all. So I tell people, my patients, when you go on the internet and you're looking at all those programs and stuff, you need to make sure it's something for you. Because again, if my pelvic pain patients go on and it's very Kegel focused, it's going to exacerbate their pain, not help it.
It's very superficial information what we
Yeah.
have out
Right.
there.
Right. Yeah. Yeah.
So I want to take a moment here because I think this is what makes your approach really special. You describe your practice as trauma informed care. For our listeners who are hearing this, our listeners who are hearing this, or may have been, or may have heard this term for the first time, what does trauma informed pelvic care look like in the treatment room?
Okay. So when the patient comes in, I don't ask, "What's wrong with you?" I
Mhm.
always ask, "How can I help you? What brings you here today?" I let them tell me in their words, or I'll say, "I have this referral for you, but you tell me in your words why you're here." And I let them tell me their story. A lot of times with especially my pelvic pain patients, but even some of my incontinence patients, they have a history of sexual abuse, trauma when they were younger that they may not have ever told anybody, and they've had that locked up in their body for so long
Yeah.
that it's causing problems. Um, and I can tell that because their body, they'll come in and their, you know, arms are across their body and their legs are crossed. It's very, so I sit across and I ask them, "Do you want to do an exam today?" I always ask permission.
Mhm.
I ask permission, "Can I touch you now?" If they tell me I don't want a pelvic exam, we don't do the pelvic exam. I do other things. I really let them guide me. I have a very safe space. And so and I always tell them, I really appreciate you allowing me to work with you. We can do this together. But again, I tell them anything you don't want to answer, you don't have to answer. Anything you don't want to do, you don't have to do. So it's very patient driven
Mhm.
and to
Yeah.
try to make it safe and
Right.
then try to work through that. And I also try to work with them to find a good mental health provider that they feel safe with, which is difficult in Roswell. But that always is great to have on top with that.
That's amazing. So you begin from the body, learning their body language, then go into permission-based care, and then
Mhm.
also help with the provider referral if needed.
Right. Right.
That is a very patient-centered approach there.
Right. It's very I don't know. I love working with those patients because they've not had help for so long and they're just feel like their life is not worth it a lot of times, honestly, with some of them. And to try to work with them to help them through that trauma and to where they again have a better quality of life is just really fulfilling.
That's amazing. And if, even for a patient, they might have held that trauma for so long, with so many number of years, and to finally have that someone who actually understands their body and not and make them feel like, okay, this is how your body is reacting. It's not you. That must be empowering.
And I do a lot of education on how, again, how the nervous system, the vagus nerve, how all of that is, their nervous system is just on fire. It's in that fight and flight cycle. And
Right.
I try to get them to understand we need it with through breathing and positioning and some stuff like this. We need to bring it down so you're in the rest and digest, that parasympathetic cycle. I'll look, and a lot of times their jaw is clenched. And that is a sign a lot of times. Some of my pelvic patients will also have jaw pain because
Mhm.
they're tense all the time.
Yeah.
Another example is I'll have referrals for patients, young girls that, well, I say in their 20s, that can't have a pelvic exam. So they feel they're broken and they're like, I'm never going to be able to have a baby because they've had such a horrible experience with the speculum that they tensed up and they couldn't get the speculum in. So I do a lot of down training, but I also have disposable speculums and I give them that and I ask them to hold it and open it, play with it at home. They bring it in and I work with them so then they can insert the speculum, but also to teach them how to breathe when they go into the doctor so that when they're doing the speculum, they're breathing and they know this is normal. This is not invasive. I need to do this. And so I've had several patients that I've just gotten them ready for a pelvic exam.
This is so validating to hear. I myself, to be honest, was so scared of this exams during my second pregnancy. I was dreading it. I
People
held it
do.
off quite a number of times until I could really not hold it off. Like,
Yeah.
do you want to do a pelvic? No.
And that's
Yes.
so normal. I mean, I have a patient in her 30s and never had a pelvic exam, hadn't had kids or whatever, but she wanted children. But she said, I'm not going to go in for a pelvic exam. I'm like, but we have to get, if you want to have babies, we got to get you where you can relax your pelvic floor muscles. But we can do that to get you ready for the pelvic floor exam, for your annual exam. And it's really interesting when they have control, when they see the speculum and they have control. And then they say, oh, wow, I can go in. And if I'm breathing, and I tell them, hold your breath and see what it feels like. And they're like, oh, yeah, I can feel my muscles tensing up. And so, yeah, so that's another kind of some people wouldn't think that a pelvic floor therapist would need to work on that. But again, that's so important to get your annual exams and to be able to do that to have a baby.
Right. See, and at least for me now, I know I whoever has to have any exams for that, I can tell, try and go see a pelvic health physical therapist. That might be
Yeah.
helpful for you. Had I known
Yeah.
earlier, I would have definitely done that.
Yeah,
Yes.
I still remember my first one, and again, no one tells us about it, and you just go in, and you're in the stirrups, and then they bring this thing towards you, and again, it's like and
Yeah,
what do most of us do? We hold our breath and we clench up.
exactly.
Everybody does it. So I again, for these patients, if they do that, no wonder they couldn't get the speculum in, and so I teach them that, like, say, if you unclench your hands, do a deep breath, and they're like, "Oh, okay, I can do this."
Okay. I'm breathing in now.
Exactly.
Oh,
Exactly.
all right. Um, so moving on, when we're talking about trauma, can stress and anxiety also affect the pelvic floor?
Yeah. So, all of those nerves, everything goes down to the pelvic floor.
Hmm.
So I tell people, again, those are muscles. So for my incontinence patients, either urinary or fecal, I tell them, when you have the flu, how do your muscles work? And they're like, well, no, I don't want to get out of bed and my back hurts and I'm very weak. I'm like, so you may have some episodes of incontinence while you're sick because your muscles aren't working right. For the stress patients, I tell them again, I go through how our nervous system affects our pelvic floor. And so I'll have patients who come in and go, I had a bad week. I was really stressful with school or whatever. And these things happened. And then I'll say, okay, well, before this day, how were you doing? And they're like, oh, I did great for the 2 weeks before. But I'm like, okay, let's get you back on track. Because what happens when we're stressed, we stop diaphragmatic breathing. We breathe from up here, very short breaths. So we're not getting enough oxygen in. We tend to tense up. So it's just a lot of different things, but stress is definitely a factor, even with my incontinence patients, but especially with my pelvic pain patients.
Yeah, yeah, yeah. Now it seems like all the dots are connecting for me. So talking about women's health, we've already spoken about it. Our pelvic floor, it goes through a lot in a woman's lifetime. Periods to childbirth. Talking about childbirth, what happens to the pelvic floor after childbirth? And we hear a lot of this term diastasis recti. Can you elaborate on that, please?
Yeah. So I like to see patients during their pregnancy.
Okay.
So I can teach them good body alignment. I work with them a lot of times, when we're pregnant, our hormones are on alert. And so our joints are really lax, are very, unstable. So some of my patients will have SI joint pain, sacroiliac joint pain. And so I may put them in a SI belt or a pregnancy belt. And so I try to start before they deliver the baby. And then about 37 weeks, I go and I do an internal exam and I teach the patient and her partner how to stretch the perineum to avoid any tearing. So we work on getting the perineum ready to avoid any tearing. And then they have the baby. And I try to talk to them about delivery positions, those kind of things. Because if you've got a patient on their back and you've got dad on one side with the hip flexed and you've got mom on this side and she's pulling the leg, but they're not pulling the same, they're going to make some problems with the pubic symphysis in the front. So I have to work on that a little bit and try to teach them not to do that so that during delivery, they don't stress that front joint, the pubic symphysis joint. So then they have the baby. And then
Hmm.
I usually see them 2 weeks after delivery. Ask them to bring the baby with them and I will check alignment. I'll check then I'll check during pregnancy too, but especially after pregnancy. I want to check to see if they have diastasis recti, which means the fascia, it splits. So you can go down and you can feel if there's any splitting or and how deep it is, how wide and how deep. Sorry, I talk with my hands, as you can tell.
No, that's
Uh,
yeah, that's
so what I do is to work with them on bringing that fascia back together and doing exercises to keep that from getting worse.
that's amazing. See, for my understanding was that this is a type that happens after childbirth, like after
Mhm,
pregnancy.
mhm.
But I did not know this was something we could work on prior to. childbirth and all the way through your pregnant, even during your
Right.
pregnancy.
Right. So I work with them on breathing and how to engage their abdominal muscles during, their transverse abdominals and the rectum, just during pregnancy also. So,
That is so great, Genia. Like I said, all that information we have about pelvic health has been so superficial, and I'm learning plenty.
right. Right.
Yeah,
Well, yeah, before and even with when I had my 4 children, you just didn't get this information.
right.
You were just kind of on your own. And then at 6 months or 6 weeks after the pregnancy, it was like, okay, you can have sex again. Well,
Mm,
the problem is there's things that can happen between birth and 6 weeks. So that we can prevent. I had a patient that had a pubic symphysis issue with pregnancy, and I got her in right away, and I could examine her, and her leg length wasn't off. So, I mean, her everything was in place, but she just had so much pain from that. And what I taught her was keeping her legs together. You don't ever want to pull your leg out. So keep your legs together when you're getting in and out of the car, in and out of the bed, some different ways to stabilize that. And it really helped with the pain.
yeah, that's a very simple and effective tip, something that you can do in
Yes.
your
Right.
everyday life. Yeah,
Right. Instead of having to wait till 6 weeks and go in and say, "Hey," because again, as you know, as a mom, if you're not feeling good, it's really hard to take care of your baby, because we're
exactly.
putting everything into the baby and nothing
Hmm.
into ourselves. So that's one of the things. And we just actually, I helped write some legislation that's in Congress right now.
That's
It's
amazing.
it's HR 74. It just had a Senate bill. I can't remember the Senate bill, but it's focusing on postpartum health and
Wow.
especially in our Medicaid population. And the legislation is to encourage providers to know what pelvic health is and the benefit of public health, and then to educate the public and women on this is why it's important for you to get postpartum care.
Oh
So,
my God, this
so
is
yeah,
amazing. Thank you so much for doing
yeah,
that on behalf of
yeah,
all the women, if I
yeah,
may say so.
yeah.
That is so much needed. And even this episode today that we're talking about right now, like I said, yeah, all that information that's there about pelvic health is so superficial, but nobody really realizes how it affects from childhood through your entire life, to be honest.
Right, right.
Thank you so much. I'm excited and I'm going to be following up on that.
Yeah, yeah. I was just in Washington, D.C. actually last month on Capitol Hill, meeting with legislators and promoting 4074. I'm excited. I hope it gets passed this year, but it's a little
Me
crazy in the
too.
government now. My priorities aren't really maybe their priorities for some, but I think it's amazing though. So we're trying to do that focus on education for both the patients and providers.
Like I said, a strong
Yeah,
advocate, at the national
yeah,
level. We have
yeah,
it.
yeah.
I'm
I
looking
try.
forward to this. When we announced this episode, everyone was super excited. The response was incredible. And one of the questions that kept coming up was perimenopause. So most of the women are not aware perimenopause, it starts almost a decade earlier than your last period hits. So what are the different hormonal transitions that our pelvic floor is transitions that our pelvic floor.
Well, I'm glad you asked that question because this is one of my big pushes is topical estrogen. So what people will start noticing are women in perimenopause, they'll start noticing vaginal dryness and that sex may not feel quite as great as it used to. And for a lot of us, we blow it off as, well, it's kids and work and not our bodies, right? Because we're taking care of
Right.
everybody else. But when you look at, I tell patients, look at your vulvar tissue, look at your tissue and see because what you'll start seeing is the color changes, it gets drier. So what the gold standard is now is for topical estrogen to start earlier versus later. And it's not systemic, so you can be on it and be on other hormones if you're on birth control or whatever. But you just use the topical estrogen the first week 3 times a week, and then after that 2 times a week. You put it inside and then along your vulvar tissue. And that changes, that plumps up and brings back some of that estrogen to that area. Studies have shown it decreases UTIs, so that's great. And so you're doing that preventative before you go into menopause. And then in menopause, you definitely need to take it. To, that's the main thing I would say on that women are seeing on perimenopause.
So we can begin as early as 10 years old, where
Yep.
your assumption is
When
you're likely to
when
hit
you
them.
start right. you'll start noticing drier tissues and it just doesn't seem the same down there. And so you can start it in perimenopause. Yeah.
That's helpful to know,
Yeah.
especially my friends, my family's all hitting that 40s. It's
Right.
helpful.
Right. And, some physicians may put somebody on oral birth control. That's kind of, I leave that up to the provider, to the physician. But for me, when I'm looking at those tissues on a table, I'll even have the mirror and show them, how the color. And then I tell my patients, I'm like, okay, this is a baseline. So when you start, I want you to look, in 2 weeks, in a month. And they're shocked at how well it looks and how much better it feels. And yeah, so it's a big change.
It is. So, does pelvic floor dysfunction affect intimacy and relationships?
Yes. So most often it can be, again, from dryness, from those hormonal changes. So the topical estrogen and lubrication can help with that. But a lot of times it's from muscle tension. So your pelvic floor muscles are overactive, which for the male, they think that's great because it feels great to them. But for the female partner, it doesn't feel great. Then what I tell them is, again, going back to our nervous system, if they're having intercourse and it hurts, but they do it because I got to do it or I want to do this for my husband or whatever. Their body tells them, look, we tightened up. We told you that hurts. You didn't listen to us. So the next time it's going to hurt worse because your body's trying to give you a signal that something's not right. And so what I do is if the patient wants, I encourage the partner to come in. I teach them breathing. And then while I'm also doing internal work to down train those muscles. And then I work with them on positions and different things like that that decrease the pain with sex. For example, if a patient has overactive muscles, that's going to be painful for her with intercourse, with penetration, or anything in the vagina. And so, what I do is encourage her, if she feels comfortable, to have the patient's partner come in and I teach him watch. Well, I teach her breathing, how to relax. He's at by her head. And then I'm doing internal work to down train those muscles. And then I explain to them, I tried because when they have pain like that and they come to see me, I ask them to withhold from intercourse for a while. Most partners are supportive, some aren't. So I asked them to bring the partner in. So I explained that if you keep doing this, it just is making the pain worse. This is not going to
Mhm.
get better. So this is what we need to do. And I need you to support her in not having intercourse while we're getting those muscles to relax. And most of the time that helps because they're hearing it from me and not just the patient. So
Yeah.
that's one of the things.
Yeah.
So, oh, go ahead.
Yeah, I know. I think hearing that from the provider point of view, from a therapist, that helps rather than just listening to the partner.
Right, right. Because then when I give them homework, when I tell her these are, I don't want you to have intercourse. Here's positions that relax the pelvic floor. There's different yoga positions that you can do, and I'll tell them, and then I'm like, so I tell the partner, I want you to encourage her. Don't force her, or not force her, but push her to have intercourse. But
Yeah.
also, I work with them on intimacy without penetration.
Mm.
And so we work on that so they still have the intimacy, and then we progress into intercourse.
Now that we're having this conversation, most men don't realize that it's not just a woman's issue. So they are very less likely to seek help. Men who are dealing with prostatitis or erectile dysfunction, they rarely think of pelvic floor. What do men need to understand about their pelvic health and how it's
Th-
connected to their conditions?
Right. They need to understand those are muscles.
Hmm.
And just like if they had a problem with their back muscles or, their biceps or their quads or whatever, if they had a problem that was affecting their life, they would go get help for that. So I try to explain, and I have, models in here that I show them how, here's your prostate, especially for my patients who've had a radical prostatectomy. I explained to them how their prostate affected how they were urinating before. And now that it's out, here's the issue. And this is why we want to use these muscles. Same for my prostatitis patients. It's a lot of down training, pain management techniques. I've had more men than women actually that I've seen that have had the anal spasms, which if that happens, then you can get constipated, which can lead to diverticulitis, or if you're a Crohn's patient. And so it's really trying to teach them about the muscles and also about relaxation, because that's a hard thing for men to, when I try to talk to them about breathing, I can watch their
Right.
eyes roll back, like, give me some, weights or something. And I'm like, no, this is a different kind of therapy. So that's a lot of it. It's just I try to really help them understand their muscles and they're no different than any other muscles in their body that might not be working right.
Yeah, it's a different kind of muscle training rather than just lifting or
Yes, right.
strength training they
Yeah.
do at the gym.
Yeah. And, for some of my men, I work with them with penile pumps after they've had a prostatectomy. I work with biofeedback and so different techniques, but the same principles. But I just approach it a little bit different with my male patients.
Their patients, so the approach is different. The thing that did surprise me was child health physical therapy. That's something that doesn't cross anyone's mind, pretty much, I guess, when we think about pelvic health. So, what are the most common reasons a child would be referred to you?
Usually bedwetting or yeah, most of the time it's bedwetting. I've had a few with constipation because like I say, if I can clear up the constipation, usually clears up for my children, usually it clears up their incontinence. So, and for a long time in the beginning of my career, I did a lot of pediatrics. So it's a natural fit for me to see kids, I feel comfortable treating pediatrics. And so the approach is a little bit different. I have to make it very goal oriented and a sticker chart and, a lot of play so that the child gets kind of takes ownership of it too and wants to do it. And it's just not on the parents. But also work if they're in school, because a lot of schools, you only go like they'll have a bathroom break in the morning and a bathroom break in the afternoon. And a lot of times the kids don't even go to the bathroom. They don't want to go in the bathroom. They'd rather go on the playground.
Yeah.
So with my kids who are having leakage during the day, I work with the teacher for a bathroom schedule. And we make up a little sign so the student doesn't have to raise her hand and embarrass herself. We do a little quirky thing, little toy deal that she just holds up and the teacher lets her go to the bathroom so that they're not holding it and not having leakage. So I work on a bladder schedule with them to do during school, but also at home.
That's interesting. This was something that I heard when we were talking in my friend's circle. A kid, yeah, she was holding her bladder the whole day and she had leakages throughout. But when we asked her why you did not use restroom, her answer most of the time used to be, I did not know.
Right.
So,
And
you know,
so I work with them on listening to your body, but
hmm
even then, if they're still saying, "I don't see it," but if I have
hmm
them on a schedule and they go into the bathroom, it kinda gets them where we start with a 2-hour schedule,
yeah,
because a healthy bladder is not going sooner than 2 hours and not waiting over 4 hours. So, what we try to do is put them on a 2-hour schedule and making sure they go to the bathroom, and then they start picking up those signals, "Oh, this is what it feels like." So but I also have some biofeedback stuff I can do with them too. But yeah.
that's helpful to know. Maybe therapy would
Yeah,
be
yeah,
a good solution for the
yeah,
problem that a child is
yeah.
having right now.
Yeah, to try to, work on it earlier than later,
Yeah.
especially, junior high, high school age, that's hard.
Yeah, exactly. Now, coming to your practice, it's truly one of the most inclusive practices I've come across, and I really want to shine a light on a community that is so often overlooked when it comes to healthcare conversations. You also provide gender affirming pelvic care.
Yes.
What are some of the pelvic health concerns overlooked in transgender and non binary patients?
Well, again, they have the same muscles that we do. So before they have surgery, I want to make sure that their breathing's good, that they understand, their abdominal contractions, transverse abdominals, that pelvic brace is there.
Hmm.
When they go from male to female, it's really important that they're on a dilator program. And so it's not just you go in and have surgery and then you're on your own, or you're on your own with a dilator that the doctor gave you. You really need to be on a progressive dilator program to make sure that you don't lose that surgical procedure that you just went through. Um, and I also try to work with because there's a big process. I know a lot of people think it's just, you go to your doctor and the doctor says, "Oh, I'm going to make you a man today or a woman." There's so much they have to do, mental health checks, all this stuff they have to do before they're even approved for the surgery. So I try to make sure that I'm working with their mental health, whoever they're working with on their mental health and their surgeon to make sure I know the surgical procedure, the type they're doing, but also if there's any special thing I need to do for their mental health, then I'm on top of that.
So,
And also calling them by their preferred name,
yeah.
because a lot of time they're not presenting
Hmm.
as who they want to be. And I still need to call them and address them by their chosen name and not their dead name.
Yeah. It could be a challenge initially when it comes to healthcare, right? Coming at
Because,
the reception and then providing the care. So, are there any unique challenges this community faces when it's seeking pelvic care?
yes, there's not enough providers of pelvic health. Yeah, there's not enough providers. And I think, again, I mean, I'm in New Mexico. It's a little bit
Yeah.
different. It's a little more laid back and a little more inclusive, I think, than Texas. My patients that I've had have been from Texas, not New Mexico, because they couldn't, and they drove 4 hours to see me for an eval at 4 o'clock in the afternoon, which meant after they finished my eval at 5:30, they're going to drive 4 hours back because there wasn't a public health provider that would agree to see them. So I think it's an access issue.
Yeah, it is. And I'm glad, at least in Roswell, I've lived in Roswell, so I know it.
Medical desert is a medical
Yeah.
desert.
But at least for those patients to be able to even have that care, I know it's access 4 hours. That is a challenge. See, driving 4 hours to
Right.
seek,
But
seek health care. Wow.
right. And I had a lady come in with her husband and she was waiting to have the surgery, male to female, and she presented female. But what was sad for her is they had started in Texas and all their paperwork, everything, and then came here. They moved to New Mexico, but they couldn't find anybody in New Mexico who would do the surgery. So they were having to go back to Dallas. So there's a gender affirming surgeon in Dallas who himself is transgendered. And I got them with them, but by the time their paperwork had expired, so they had to start the process all over. So again, there's just lots of, I mean, if someone who's doing this is very dedicated in doing it, and I just hate that there's so many obstacles to let them be their true self. So that there's so many pieces that they have to, me or the surgeon, the insurance, the psychologist, it's to get all that on board. It's a lot.
Right. And align that together, the appointments, even those are hard to come by. For even coming to you, they have to see a primary care first and then
Right,
come to you. So
right,
those appointments have to line up. There are so many moving parts that have to
right.
line.
And there's just a lot of providers that are not comfortable with that.
Mhm.
And so that makes the access issue even worse. So,
Yeah. And that is why I found your practice is very special that is providing that
yeah,
care. Is
yeah, yeah. I try to, and that's the thing. People ask me, well, what do you specialize in? And like I say, when I first started, I was just seeing women with urinary incontinence. But then again, I started seeing coccydynia, and it just kept. Then I started seeing men, and then their kids, and then I got a call out of the blue from this patient in Texas, and then they told somebody else. And so it's just, from being here, it's a rural area and you have
Mhm.
to be kind of a generalist. So
Yeah.
it makes my continuing ed very interesting because I'm always like trying to learn new things to help my patients. So
We're in age of AI tools are being developed to help diagnose endometriosis and other pelvic conditions. As a clinician, do you see physical therapist role evolving alongside these technologies?
yes, I do because we work with a lot of surgeons. I try to educate my patients to choose surgeons that are qualified in excision instead of ablation because that's the standard. You want to have, if you have endometriosis, which a lot of times, you have to go in and surgically determine that. But you want to have somebody who can excise it rather than ablate, ablate the lesions. And also, you don't want to go to somebody who is their answer to endometriosis is, "Are you finished having children? Well, then we'll just do a hysterectomy." A hysterectomy does not fix endometriosis. So, what we are working with, we work with endometriosis specialists and try to educate our patients on, getting to the right person that can help them with their endometriosis because that can affect your childbearing, that can cause horrible pain. I just had a patient that went from here to Dallas to a specialist, and she was only 24, but she had been told she needed a hysterectomy. I sent her to an excision specialist in Dallas, and he did the excision, took away her abdominal pain that she'd had since she started her period. She has her uterus, so she can go have babies when
Yeah.
she's ready. But that was the answer she got was, well, you probably have it so bad, we'll just do a hysterectomy. And I happened to be seeing her for pelvic pain, and she had this abdominal pain. And I said, if you're willing, why don't you have a consult with this doctor? And his approach was totally different. So we're working hand in hand. I'm
Hmm.
a member of OGS, which is the American Urogynecology Society. So I work with physicians there, and then we have just a lot of different interactions with specialists. So we try to work together to treat with evidence-based care and not the hysterectomy.
Yeah.
Yeah,
That's so
yeah,
important. Like, I mean, just to say, go and get a hysterectomy, 24-year-old. But
yeah, lie. Yeah.
yeah, thankfully she had
So,
you. And
yeah,
oh,
I tried to treat her like my daughter, and I just thought I would be so mad, "No, you don't need to do this." So, yeah.
that's amazing. And not everybody gets a therapist like you who really think about patient as their, like you said, your daughter, and think about what would I do for my
What
daughter?
would I do,
Because
daughter?
then your approach is totally different when you think of your patient like that. When you think about,
Right.
okay, this could be my son, this could be my daughter, this could be my grandchildren. So then your approach totally takes a different form. Yeah, yeah. This has been an incredible conversation, Kim. And to close out, if our listener could just do one thing for their pelvic health starting today, what would you tell them?
I would say be on a good bowel and bladder program, because again, that can cause pelvic pain, some of those issues. It can cause UTIs if your bladder is schedule is off. So I would say that, along with drinking more water, but just paying attention because again, when patients first come to me and they're valid, I'm like, well, how many times a day do you think you're urinating? And they couldn't tell me. But when I say, how many times a night are you waking up? And they'll say, well, 3 or 4. I mean, I have some people that are waking up every hour of the night. So if, and which is a fall risk if they're older. So again, a good bowel and bladder program, just understanding what's healthy and what's not is going to be a good start.
Thank you. There you have it, listeners. That was a wealth of information for you all, as it was for me. For our listeners, where can they find you, Kim?
I'm at Renew Physical Therapy. I have a website, and I'm in Roswell, New Mexico.
Thank you. So you know where to reach out, folks. Thank you so much, Kim. This is exactly the kind of conversation Myths to Medicine exists for, taking what lives in the doctor's office and bringing it to everyday life. To our listeners, share this episode because someone you know needs to hear this today. Whenever I heard it, someone you know definitely needs to hear it. Thank you.
Thank you so much.